Very often, when we get unwell, doctors recommend us to go for some laboratory testing done. In the situations when we go for specific test, there are often more than one test are available for one diagnosis. In this module, we will be talking about how do we determine if any new test that has been proposed is really an efficient test to be performed, and should it be preferred over some existing test. So, tests are used in clinical diagnosis and screenings. In the health sciences, they have the wide use and application. And they often use probability laws to determine if any diagnostic test is effective or not. Clinicians look for enhanced ability to correctly predict the presence or absence of a particular disease from the knowledge of test results. Whereas the biostatisticians look for the information regarding the likelihood of positive test results or negative test results in the presence or absence of the disease or any symptom in our subjects. Then the question comes that how well is a subject classified into the disease or non-disease category? Ideally, every person who is having the disease should be tested as having the disease as an outcome of the test. Whereas any person not having the disease should be diagnosed as not having the disease. But practically speaking, all tests are not always infallible. The ability to classify individuals into the correct disease status depends upon the accuracy of the tests. A diagnostic test is used to determine the presence or absence of a disease when a subject shows signs or symptoms of a disease. Whereas a screening test identifies asymptomatic individuals who may have the disease. So the diagnostic test is performed after a positive screening test has established effective, definite diagnosis. Some common screening tests which are performed is like fasting blood cholesterol for heart disease. It could be fasting blood sugar for diabetes. It could be blood pressure for hypertension, mammography for breast cancer, PSA test for prostate cancer, and fecal occult blood test for colon cancer are few of the examples. But there is a huge variation in the biological values. Many test results have continuous scale, like if we talk about the blood glucose level, it could be 70 to 100 milligram. Similarly, cholesterol level could be less than 100. And similarly, blood pressure could be systolic blood pressure. Its normal ranges are 120, and diastolic blood pressure has normal range is 80. So distribution of these biological measures in human may or may not permit easy separation of a person having disease or not having a disease, especially based upon the value of the measurement we make. But in summary, the following questions must be answered in order to evaluate the usefulness of the test results and symptom status in determining whether a subject should be classified as having the disease or not. The first question should be responded as that given that the subject has the disease, what is the probability of positive test result? The other question that should be answered is that given that a subject does not have the disease, what is the probability of negative test result? The third question that should be answered is that given a positive screening test, what is the probability that the subject has the disease? And then lastly, given the negative screening test result, what's the probability that subject does not have the disease. One must know that the correct disease status prior to the calculation. We often use a gold standard test. Gold standard tests are most often invasive or expensive, but the results coming out of the gold standard tests are always considered to be the superior results as compared to any other test. So whenever we develop a new test, we always try to compare it with the gold standard test to see the effectiveness of it. Whereas when we propose a new test, it's most of the time it's less expensive or it has a higher power to diagnose. For this, we use a 2x2 table to compare the performance of a new test and already existing gold standard test. This 2x2 table has, on the column side, it has the outcomes from the gold standard test, whereas on the row side, it has the new test results. A person showing positive here must be having a disease, and the person showing negative are those who do not have the disease. Whereas this reflects the people, the respondents, who tested positive, whereas these will reflect the respondents who tested negative from the new test. Over here, in this contingency table, you might notice that there are A, B, C, and D are represented in 4 cells of this 2x2 table, where A represents true positive. True positives are the ones who actually have the disease and the test has diagnosed them as positive. Whereas D reflects true negatives. It includes the individual who do not have the disease, and a new test has also determined that these individuals do not have the disease. Whereas B and C are called false positive and false negative. When we are testing, we have to take care of these false positive and false negatives. And these values should have to be minimum, because if we look at the false positive, these are those individuals who tested positive in a new test, but in reality, they do not have the disease. Whereas the false negatives are those who tested negative, but they actually do have the disease. The measure that we often use to determine if a new proposed test is better than the pre-existing gold standard test, one of those measures is called sensitivity. Sensitivity of a test is the probability of a positive test result given the presence of the disease. In other words, we can say that sensitivity is the ability of the test to identify or correctly identifying those who have the disease from all individuals with the disease. So in this contingency table, you might notice that A are the ones who are tested positive and they actually have the disease. And so if we talk about the sensitivity here, sensitivity is the probability of testing positive such given that they are actually diagnosed as positive. So sensitivity can be written as A divided by A plus C, where A represents true positive and A plus C represents those who actually have the disease in reality. The other measure is specificity. Specificity of a test is the probability of a negative test result, given the absence of the disease. In other words, we can say that specificity is the ability of a test to identify those who do not have the disease from all the individuals which are free from the disease. Specificity is also a fixed characteristic of a test, like sensitivity. Specificity is simply obtained by dividing the true negatives by all those who do not have the disease in reality. So if a person tests positive, then the question comes that what is the probability that he or she has the disease. The other question that arises is that if the person tested negative, then what's the probability that he or she does not have the disease? To determine these values, we look at the positive predicted value, and another measure is called the negative predictive value. The positive predicted value of a screening test is the probability that a subject has the disease, given that the symptom has positive screening test. Or in other words, we can say that positive predicted value, which is denoted by PPV, is the proportion of patients who tested positive who actually have the disease. We have given the formula for PPV, but this determining of the positive predictive value can also be observed by the Bayes theorem, which is, if we look at this formula, it looks very, very confusing, but apparently it can be obtained with a much simpler formula using these 2x2 table. The other value is the negative predictive value. Negative predictive value of a screening test is the probability that a subject does not have the disease, given that the symptom has negative screening test results. Negative predictive value is the proportion of patients who tested negative but actually do not have the disease. So these, likewise, PPV, we can determine NPV using the Bayes rule or dividing the true negatives by C plus D, which is all who are tested negative. Estimates of the positive predictive value and negative predictive value can also be obtained by having the knowledge of sensitivity and specificity and the probability of the relevant disease in the general population, which is called prevalence. We have those formulas which involve all these measures like sensitivity, specificity, and prevalence. We can use all these measures to obtain the values of PPV and NPV. Sensitivity, specificity, positive predicted value, and negative predicted value. All these measures help us to determine the effectiveness of newly introduced diagnostic test. Having higher sensitivity does not necessarily mean that specificity will also be higher. One needs to find a good trade-off between all these four values.